So thank you to everyone for joining the International Federation on Aging, also known as IFA today, for the Case for Investment in Health Prevention and Promotion webinar. My name is Sheila Amory, a project officer at the IFA. This webinar is part of a series to build global momentum for adult vaccination within COVID-19. The IFA would like to thank Pfizer for sponsoring the series. Today, we will be hearing from two expert speakers. During their presentations, you'll be able to ask questions in the chat box, which will be readdressed during the moderated discussion after both speakers have presented. I will now turn it over to Dr. Jane Barrett, Secretary General of the IFA, to introduce the speakers.
Thanks very much, Sheila, and good morning, good afternoon, and good evening to all those that are attending this important webinar. As Sheila said, building global momentum for adult vaccination policy within COVID is a series that focuses on three key vaccination-related policy areas that IFA focuses on in our work: prevention, access, and equity, within a rights-based approach. Gathering and mobilising knowledge at this critical time in global public health policy is necessary to advocate for implementation of immunisation policies to global stakeholders, but also at a national and local level, in line with the Immunisation Agenda 2030 and, of course, the UN Decade on Healthy Ageing. Evidence on the social and economic value and return on investments of vaccines underpins governmental decisions on immunisation programs, hence the name, the Case for Investment in Health Prevention and Promotion. In this webinar, we have two excellent speakers. Dr. Jean-Pierre Michel will describe the application of P4, predictive, personalised, preventive, participatory medicine in the context of adult vaccination. And this presentation will be followed by Dr. Brian Patenaude, who will speak to the return on investment of adult vaccination. These presentations will be followed by a moderated discussion with the aim of better understanding the efforts required to improve targeted investment in health prevention and promotion. It's now my great pleasure to introduce dear friend and colleague and mentor, Dr. Jean-Pierre Michel. Let me just a touch, talk to you about Jean-Pierre. He is Emeritus Professor and former head of the Academic Geriatric Department at Geneva Hospitals and Medical University. Dr. Michel is also Honorary Professor of Medicine at Limoges University in France, Beijing University, McGill University, and more recently, Rabat University in Morocco. As you will see in the chat box, you know, Dr. Michel's bio is extensive. But what I know is his warmth, his encouragement, his support, and his expertise in this area across the line of geriatricians and geriatrics. Please welcome Jean-Pierre Michel. The floor is yours, sir. Wonderful. Perfect.
Not this one?
I think it's good. You could put it into a slideshow, but whatever. Oh, perfect, Jean-Pierre.
Thank you very much. Thank you for this nice introduction, James. I am pleased today to speak with you from Geneva about the application of P4 medicine to immunization. And in fact, I would like firstly to remind you that in 2015, the World Health Organization published the first global report on health and aging. And within the preface of this report, Margaret Chan, who was the previous director of WHO, wrote this very important sentence: healthy aging is more than just the absence of disease. And in fact, in the report itself, the definition of healthy aging was the following: process of developing and maintaining functional ability that enables well-being in older age. In fact, this definition is very important, and I am supporting it very much, because there was a very important paradigm shift between the previous definition of healthy aging, which was free of diseases, and now the functional aging, the functional well-being. And I think that vaccines have a very important role to play in this way. And I will try to demonstrate to you how vaccines are useful for promoting healthy aging. In fact, as said by Jane, the P4 medicine applied to vaccine include the first P, which is preventive. And in fact, when you are looking at different countries, as Australia, Canada, United Kingdom, and USA, you can see that there is a decrease in morbidity and mortality from pre-vaccine area to modern era. And you can see that in the different, for the different vaccine, there is a decreased incidence of the disease by more than 80, 90, even 100%. So vaccinations are really very active to prevent infectious disease. And in fact, WHO said that today, vaccines save annually more than 2.5 million deaths from communicable disease. Before the COVID pandemic, it is between 1990 and 2020, communicable diseases worldwide decreased from 33% of the total deaths to 19%. And in fact, when you are preventing infectious disease, you are also preventing post-infection functional decline. And it is well known that very often any infectious episode are linked to functional decline. And this study, which include more than 900 patients hospitalized for acute respiratory infection in persons over the age of 79, you can see that mainly the main outcome or functional outcome are very bad because there is an increase in functional disability, which raised around 19%, and increased catastrophic disability by around 10%. So by preventing the disease, you are also preventing the post-infection functional decline, which are so important to consider in the new definition of healthy aging. But in fact, vaccines are also very important to prevent a few non-communicable non-communicable disease. For example, vaccination in children can decrease the type 1 diabetes by 15 to 37%. Herpes zoster vaccine in adults over the age of 65 can decrease the incidence of stroke by 50%. Flu vaccine in adults, 8 adults, decreased cardiovascular mortality by more than 50%, and pneumococcal vaccine are decreasing coronary heart disease by around 17 to 20%. So what I told you until now, that really we know quite well now that in fact, vaccines are really preventable. They prevent infectious disease, they prevent post-infection functional decline, and they prevent a few non-communicable disease. The second P of P4 medicine is personalized. And when you are thinking about diabetic patients, we know quite well that the diabetic patients have an increased risk of developing serious and severe infectious disease. And when you are thinking about only influenza disease, and we know that observational and serological study that allow us to say that flu vaccine increase or improve the patient outcome, all the patient outcomes, and especially decrease hospitalization and decrease death. And all guidelines on diabetes advise for vaccination. Another point which is very important to consider is that in my first E, I spoke about preventing cardiovascular disease. But when you have a cardiovascular disease as heart failure, it was shown now that flu vaccination was very effective. And in this study, a Danish study, including more than 130,000 participants over the age of 18, suffering from heart failure, you can see very clearly that in fact, one shot of flu vaccine or even several shots of flu vaccine prevent all cause of death, which is very important to consider. Another study from Taiwan, which is a longitudinal health insurance data set, can see that in patients over the age of 55 with chronic obstructive pulmonary disease, 7,000 patients were included into this study. You can see that the fact that getting one shot of flu vaccine or even several shots of flu vaccine prevent all acute coronary syndrome, and it is very significant. Another Taiwanese study containing chronic kidney diseases and with the same goal of knowing if flu vaccines are preventing acute coronary syndrome, you have quite the same scheme. And you can see that if you are not vaccinated, you have more risk of developing acute coronary syndrome than if you get one or several shots of flu vaccine. And another time, this study showed the very significant effect of flu vaccine. So to summarize what I told you until now, you can see that personalized vaccines are very useful for diabetic patients to prevent any infectious disease. It was useful for coronary vascular diseases to prevent any cause of death, and for respiratory disease and cardio and chronic kidney disease to prevent coronary heart disease. What about the third P of the P for medicine applied to vaccine, which is predictive? When you are looking at the effect of pneumococcal vaccine on herd immunity, it was really very impressive to show or to see that in fact, the introduction of the pneumococcal conjugate vaccine 13 decreased the incidence of invasive pneumococcal disease. And this is very true because it is between 2.0 to more than 61%. And in all the cases, you can see that there is a decrease of invasive pneumococcal disease. And what is very surprising is that the adults over the age of 65 who benefited the most of the introduction of the vaccine in children. If we are continuing with the pneumococcal vaccine, you can see that between 2009 and 2013, the introduction of the pneumococcal conjugate vaccine 13 decreased a lot and very significantly the antimicrobial resistance of macrolide, cephalosporin, tetracycline, and penicillin. And it was really surprising to know that until now, this major effect of vaccine in preventing antimicrobial resistance was not so well known and well established. Another point, which is more critical, is in fact the influence of infant vaccination on old age dementia. And this study from Canada was a prospective study, including 3,800 cognitively impaired participants over the age of 65. And the authors of this study tried to rely this dementia onset with previous vaccination. And they found that after adjusting for age, significant association was found between a lower risk of Alzheimer's disease and exposure to diphtheria, tetanus, polio, and flu vaccine. Indeed, this study was very impressive but she was not repeated. And in fact, she started the idea of having one infectious disease as cause of dementia. But indeed, this hypothesis is still controversial and could be discussed. But when you are summarizing what I told you until now, for the third P, predictive, I show you very clearly that vaccine can increase herd immunity, increase community protection, decrease antimicrobial resistance, and could influence the onset of old age dementia. What about the fourth P of participatory? When you are looking at thinking about participatory, we have first to think about ethical issues. And when we are in the community, when individuals are in the communities, they have their personal autonomy, their individual freedom to protect themselves and to protect their own surroundings. But when we are speaking about the healthcare professional, indeed, the healthcare professional have exactly the same personal autonomy, the same individual freedom, but due to their profession, they have also to think about the most important ethical issues, which are beneficence, non-beneficence, and also their duty concerning the community and their patient. So depending on this ethical approach of the public and of the healthcare professional, the vaccine can be refused, vaccination can be refused, people can be hesitant or take, indeed, to uptake the vaccine. But what is very important behind these ethical issues is, in fact, the problem of health and vaccine literacy. Health and vaccine literacy corresponds to the process of enable people to increase control over and improve their health. And what is very important is, in fact, the access to health information. The access to health information is key, but after that, the information has to be understood, appraised, and the people have to apply what they decide. And all this process depends of the knowledge, skills, motivation, and confidence, but depends also not only of personal determinants, but structural, societal, and environmental components. But all these health and vaccine literacies are very important to consider concerning the comprehensibility of the messages, concerning the meaningfulness of the messages, and also the decision taken at the end of the process. So this process is very complicated, and there is very open an interaction between individuals, consumers, and the healthcare professional. And the healthcare professional have a very important role to try not only to give information, not only to try to check the correct understanding, to adjust the information, but also to reassess the comprehension of the consumer. And this relationship is very important. And sometimes healthcare professionals, I don't have the skills necessary to communicate in a good way. And this process is very important because it is at the end the declic for having vaccine confidence, vaccine delivery confidence, and also to decide the patient to take the vaccine. So when I spoke about the fourth P, which is participatory, we indeed have to think about ethics. We have to think about vaccine literacy. We have to think also of the healthcare professional skills and the relationship between consumer and professional. What I show you until now are the application of the 4P medicine to vaccine. But indeed, I did not speak about something which is also very important to consider. It's not only the benefits of the vaccine, but also of the possible adverse side effect of the vaccine. And what is very embarrassing for each of us is, in fact, that we have to include in this P4 medicine two other components. The first one is in fact the psycho-cognitive aspect with the cultural, the difference of cultures, the beliefs of each of us, the emotion that we feel, and also our own behavior. But this component, which is very important, is also modified by the public. Do we trust in the government? Do we trust in the medical Ministry of Health and what's said? Do we trust about what your family is thinking, how your friends are interacting with you? What about your colleagues? And most importantly, what are the media saying and what is the place of social media? And misinformation are very, very important. And perhaps we are of lack of good information, and misinformation are devastating. And in fact, recently, it was said that probably artificial intelligence could be very useful to change this aspect of misinformation. And in JAMA, recently, it was said that we need to have a new strategy to advance public health messaging. And this is by deploying countermeasures for misinformation, to have a control of digital data to inform the public, to be sure that we are speaking of trusted messengers, and we have also to promote equity through messaging. And indeed, if we have the chance of having a good communication, I am quite sure that it will be possible to regain the public confidence in vaccine and vaccination. And I show you until now, I show you what is the P4 medicine applied to vaccine. Preventive, personalized, predictive, participatory, but two other components have to be taken in account: psycho-cognitive aspect and the public concern. And when you are realizing all these things, you have not to speak about the vaccine, but we have to speak about the vaccination, which is much more important than vaccine. And immunization, vaccination is very important to promote healthy aging. With that, I would like to thank you for your attention. Thanks so much.
Thank you very much, Jean-Pierre. You know, this was a real journey, wasn't it? You know, you took us from one point in terms of, you know, the prevention, and you took us through the 4 Ps, but you did surprise me. You know, the addition of, you know, psychocognitive and public.
Very sorry.
Do you know that I'm talking to myself? So thank you very much for letting. And I think that I just have to start again. All right. What I was saying, Jean-Pierre, was that you really took us through a very important journey, you know, and the journey starting with prevention. But what did surprise me was, you know, the aspects of the psychocognitive and also the public that you connected there. One aspect also that is not often discussed in this kind of environment is discussing side effects, you know, and the side effects that impact our decision making. Another element for me was your extraordinary in-depth knowledge about the impact of vaccinations for people with non-communicable diseases. And it's not an area that we touch on very often at all. And as you know, IFA is very vocal in the importance of patient organisations, diabetes, lung, asthma, heart, coming to the table and understanding the implications. So I found it breathtaking in its detail and really informative for me. So thank you much for your time.
I think you're muted again.
Thank you, Brian. And I'm sorry to everyone. I don't know what happens to my machine sometimes. It has its a mind of its own. So let's start again. My apologies. Our next speaker is Dr. Brian Paterno. And Brian is an economist at the International Vaccine Access Centre, an assistant professor of economic evaluation at the Johns Hopkins Bloomberg School of Public Health Department of International Health. You know, at IVAC, Dr. Paterno leads the Decade of Vaccine Economics project and the Vaccine Economics Research for Sustainability and Equity. You know, Dr. Paterno has experience working in over 20 countries, and prior to joining the faculty at Johns Hopkins was the senior economist for the Office of HIV/AIDS Sustainable Financing Initiative at USAID. So we welcome you, Dr. Paterno, and thank you for your time this morning.
Thanks so much. And so I'm sharing my screen. I hope you all can see that. Great.
Yes, Brian. Yep.
Perfect. So I'm going to talk about measuring the economic impacts of vaccines. I'm going to start off with talking about some of my work with the Decade of Vaccine Economics, which primarily focuses on pediatric vaccination, and then move into sort of the gaps in what we need to fill in creating a similar analysis for adult vaccination, which my team is working on now, and sort of what some of the complexities are and relate that back to the presentation you all just heard. So the main question for our work on the Decade of Vaccine Economics project was to answer, how do we measure the global impact of investing in vaccines, and particularly those vaccines that have been supported by Gavi, the Vaccine Alliance, in low and middle income settings. So our project scope covers 94 countries. My team works in countries other than this to do similar analyses, but this project covered this scope of work, and it included 10 antigens. So these were measles, yellow fever, Hep B, a number of different vaccines for these diseases in each of these settings. And we seek to measure sort of what was the impact of these vaccines during the Decade of Vaccines from 2011 to 2020, and what the future impact would be given rollout of new vaccines, rollout of these vaccines, and increases in coverage for 2021 to 2030. So this is sort of what we were thinking about when we did this. Obviously, the case for adult vaccination is going to be a bit different. It's going to be in some different settings, and a lot of these vaccines are going to be new vaccines in some of the Gavi countries. So there's a number of different things that one needs to consider, but the framework for thinking about it is similar. So now I'm going to move in sort of to the framework of how economists think about vaccine and return on investment for vaccines, and how you quantify in economic terms the impact of these vaccinations using both financial and economic evidence, but also the health impact and health evidence that we just heard about. So there are two key methods that we use as economists for measuring the impact of vaccines. So the first is called cost of illness, and this really focuses on the cost of illness averted because you were vaccinated. So because somebody's getting vaccinated, they're not getting sick with a particular disease, they're not generating those costs to the health systems incurred by treatment. So these are things that include treatment costs, transportation cost to facility, and then additional things like wages from caregivers. So if you have informal care for adults, if you're being cared for by family, the amount of labor that goes into that, and then any productivity loss due to disability or premature death that you face. So for children, this is fairly straightforward. We can measure productivity loss as future employment, and we can measure productivity sort of through those lenses, but in older populations, this becomes very different, and what this looks like is different. And I would add that from the previous presentation, we talked about sort of the transition of moving from being free from disease to functioning well. And you can see here that the things that are sort of taken into account in the traditional cost of illness averted approach deal with that free of disease state and don't quite get at that functioning well, which we know is a really important part of adult vaccines. To try and capture some of that, there's a secondary method which we use in pediatric vaccination as well, called value of a statistical life, which sort of applies this value on average that society places on saving a life without respect to a person's wage or productivity, and uses that as a way to sort of assess some of the benefits that vaccines have in terms of that. Again, this is very highly focused on mortality, and I'll talk about how that needs to change in our framework for looking at adult immunization in just a bit. The good thing is that immunization program costs are sort of very similar to what was done in this previous work and very easy to translate. And so we're quite far ahead on sort of estimating the costs of introducing vaccines and scaling up adult vaccination and delivering adult vaccination, and more work on our part needs to be done on sort of the economic benefits. But I'll highlight sort of where we went with pediatric vaccination and where we're going with adult vaccination next. So for Gavi countries, it was very easy to get data on a lot of the different costs for the vaccines and prices and the cost of delivering the vaccines, because there's a very central repository of data for the countries that fall under Gavi. For other health systems, this needs to be obtained directly through health systems, and there's a number of ways to do it. In the US, you can get data from a number of different sources, including claims reimbursement rates and things like that, and procurement prices and a number of other settings as well. But this is where we got it for that work. I want to highlight what we found in some results from the pediatric vaccination, and then moving into adult vaccination, I'll kind of set that in context. So what we found is that, for every, on average, we found about $28.4 billion in total costs were incurred through vaccination, and they were varied through different vaccines. So you can see here, there's a number of different antigens that we looked at. One of the key drivers for pediatric vaccination in terms of costs were some of the newer vaccines. So you can see PCV and HPV start to have rising costs because these are new vaccines that were introduced. You're going to see a similar structure as you introduce new adult vaccines into a system, that they'll probably start off incurring a bit more of cost, but that's nothing to worry about, because we can take a look at these benefits. And what we find is that the benefits of pediatric vaccination using our two different approaches exceed those costs, or the $24 billion in costs. We see $1.5 trillion in benefits using a cost of illness approach, which tends to be more conservative, again, only focusing on those reductions in the treatment costs that would go into dealing with those cases of future disease. When we take into account the value of statistical life and some of those greater benefits that you can realize, we see that it's about 3.4 trillion, which results in a return on investment of about 51 to 1 using that value of statistical life approach. So for every $1 invested in these Gavi vaccines, you can see a return of about $51. And for every dollar spent using the cost of illness approach, so just the cost averted, you save about $26 in the averted costs of future illness. So these are huge returns, even though the cost of these vaccines programs are large, and those returns are expected to hold in future decades, even as new, more expensive vaccines are introduced, and even as you're trying to reach those harder to reach populations, as coverage increases, we still expect those sort of results to hold based upon the dynamics of disease and infection in those settings. And we've used these numbers for a number of different purposes. We've used them for advocacy and advocating for replenishment of Gavi. They've been published in the report. They're being used into determining some of the costs and the impact of the Immunization 2030 agenda going forward with the WHO. And now these methodologies are being adapted to take a look at adult vaccines. And we take a look, I guess I want to jump real quickly to talk about what we're doing at the country level to give a little more context into this. So we do work with each country that is included in this analysis to do a deeper dive into sort of the costs that go into the healthcare system. And we interview patients and caregivers to get an idea of sort of what the costs are that are incurred, what the realities are of treatment are on the ground in different settings for cases of disease that are vaccine preventable, and what the costs are associated with caring for children. This is a similar setup that would need to be done for adults, particularly in low and middle income countries where there's less data on sort of the impacts of adult vaccination and the impacts of aging in general. So I'm going to move now into talking about some of the determinants of costs, and then we'll jump ahead into what needs to change to think about doing this from an adult perspective. So some of the things we think about when we think about cost of illness for pediatric vaccinations are sort of the cost to the healthcare system. So shared capital, dedicated capital, overhead costs, medical staff, the medical procedures that are actually done. These are all the resources that go into treating a case of disease that might have been vaccine preventable. And this is all on the healthcare system side. But there are also costs on the patient and caretaker side. And these are similar to what one might expect with aging adults as well. So you have these overall costs. If you have out-of-pocket costs for adults that go into being treated, you have registration and consultation, you have investigations, you have medications, you have any hospitalization or transportation costs, and then productivity loss. So when we talk about productivity loss for children, we often think about the fact that either there are long-term morbidity associated with an infectious disease that might have been preventable, that limit functionality in life and the ability to work, or we think about premature mortality. And a lot of the benefits we see from pediatric vaccines are in premature mortality. When we move to thinking about adult vaccines, we really need to start focusing more on the morbidity aspect. Like, yes, there's premature mortality, but the premature mortality is often in, less than decades. Whereas for a pediatric vaccination, that can be, dying below age 5, and the rest of the expectancy of life is several decades, which puts a heavy weight on mortality for valuing those vaccines. For adult vaccines, it becomes more about talking about morbidity and valuing productivity in a way that makes sense for a population that may not be in the labor force and may not be working. So sometimes when we think about productivity loss for children, we use labor force participation and sort of average wages and productivity or GDP per capita as a way to value what their future earnings might be, and incorporating that into some of the benefits of vaccination. For older adults, we need to think about different ways that we measure that, how we measure functional impairment, so the reduction in quality of life for daily living, in economic terms, even though that may not have a real tangible productivity value in terms of labor participation. How we value things like volunteer labor, and how we value caregiving that may be informal. So when you have children caring for older adults to some capacity, and not necessarily informal systems. But we still have two key ways of thinking about this, and there are two audiences that sort of this case needs to be made to. So one is the healthcare system, and one is, the overall society, and how we view this from a holistic policy perspective. And we've found as a team that in the settings that we work in, it's often best to split those and present both, because there are very different actors and policymakers who have a vested interest in each part of this, and who need to be able to see the benefits on both sides. So you can see here from a cost of illness perspective, we sort of have these healthcare system costs and these costs to patients and caregivers. As a policymaker, particularly in low and middle income countries, when you're analyzing budgets that have a very particular focus, and there may not be sort of holistic data from census or from other studies that give you a real detailed picture of what households' economics look like, you're going to be very focused on the healthcare system costs and sort of how that relates to budget line items. So being able to pull out the cost to healthcare system and separate that from the more holistic costs is often very important for advocacy, because these are the types of things that can be tracked on budgets. You can link 1 additional, 2 additional vaccines to averted future healthcare costs when those healthcare costs appear on budget. So this is what we call a government perspective, taking into account all of the different portions of medical and non-medical costs that one would reasonably expect to appear on a government budget. So these are things like averted healthcare costs from facilities and treatments, the costs of dealing with the supply chain to get those treatments to and from that facility, time spent, labor spent treating these diseases. So the very standard free of disease model is still important to estimate, even in the context of all of the other things going on with adult vaccination as it was in pediatric vaccination, because these are the things that are going to appear on government budgets, especially for countries that have national health systems. Investing in pediatric vaccines, as we all know, and investing in adult vaccines have impacts on containing costs for those same health systems on the other end by preventing really expensive treatments. So while treatments for pediatric vaccination may not be all that expensive in higher income countries, treatments for many of the adult vaccines are. And as we just heard, there are interactions between adult vaccines for infectious disease and chronic conditions. And chronic conditions are some of the conditions that drive healthcare expenditure in high income settings. And so if there is interaction between relatively cheaply provided immunizations and expensive treatment for chronic condition, those are important cost savings to take into account. I'll highlight here some of the ways that we've presented the data in detail in some of our countries and what we plan to do for adult vaccination as we're collecting more data. So here's an example from Uganda where we've taken the average cost per episode of measles and sort of split it out for what it means in real terms throughout the population for a household and for the public sector. So you can see here how much individuals incur, how much the government pays for in terms of their contribution to this, and then how much is paid for out of pocket, either through direct medical costs or indirect medical costs for a case of illness. And we see how this breaks down throughout the population. So for this instance, for pediatric measles in Uganda, we find that the average cost per episode was about $52, and that caregivers pay out of pocket about half of that. And that's a small amount of money when you're thinking about higher income or upper middle income country health systems. But in these settings, that can be huge. And so you can see that for those in the poorest asset quintile, 90% of caregivers who are faced with an episode of measles face catastrophic health expenditures. So that's more than 40% of your household income after food on a case of measles. And so they needed to seek ways to pay for that outside of their ability to pay through income. And only 20% could use any kind of savings. So this is actually pushing people into poverty. And we can take a look at this breakdown in terms of asset quintiles, or in terms of gender, in terms of other important socioeconomic variables that we care about. And we can do this similar type of analysis for adult vaccines and in different settings, just taking into account sort of the costs that are incurred through different types of treatments, whether that be for chronic conditions or not. So we hope to put together data like this for country profiles based upon adult vaccination. And we're working right now with the introduction of PCV 13 in Ecuador to examine some of this work and how it affects children and adults. So as I mentioned, there are a number of additional factors that need to be considered when thinking about adult vaccines that aren't here. So the first is the medical interaction between vaccine preventable illness and chronic conditions. As we heard in the previous presentation, there are new data that are being coming out every year that sort of highlights the interaction between vaccine preventable illness and chronic conditions. Our team at the International Vaccine Access Center is working on compiling a database of these interactions to try and document the epidemiological and the medical interaction between vaccine preventable illness in older adults and chronic conditions. The reason for this is bullet number 2, which is this averted medical costs portion of the economic value of vaccines. And that if vaccines are preventing chronic conditions, in addition to the diseases that they're targeted at preventing, so for instance, pneumococcal or influenza, then we're seeing additional benefits. And often those chronic conditions are what comprise a vast majority of costs among older adults in terms of the health system in higher income countries, where health costs are ballooning and expanding every year. So it's extremely important to document those interactions between potentially extremely expensive care in older adults and vaccine preventable diseases. The second is valuing labor and valuing productivity. I brought this up before, but new ways of valuing sort of volunteer labor and post-employment time. So this doesn't necessarily mean applying, sort of GDP per capita or future wages or just applying a wage rate, but thinking how one can assess this a little bit more directly. So one way to do this is through questionnaires and sort of getting people in a representative sample to think about their time and think about sort of trade-offs that they make in life that have to do with money, but also in their leisure time or their other time, and try and develop value for this. Another is to use shadow pricing, which is a way to assess in dollar terms the value of time that doesn't necessarily incur a wage. The next thing we want to think about is caregiver labor, and in different countries, caregiver labor is more and less formal for adults in general. And so I've mentioned this before, but thinking about quantification of caregiver labor in a way that is captures sort of the balance between informal and formal labor in different settings. And the next is quality of life and functional capacity. So we have, as economists, really detailed ways of measuring quality of life and less detailed ways of measuring functional capacity. And so part of what our team is thinking about and doing is developing a framework for assessing the economic impact of functional capacity in older adults, which requires a lot of thinking about what that means in addition to sort of the typical ways that economists think about quality of life and quality of health. So if you're familiar, there's terms called quality adjusted life years or disability adjusted life years, which talk about the reduction of an individual due to a specific disease state from full health. And those are well known and well documented in the public health sphere, but don't often incorporate sort of functional impairment beyond physical impairment. Sometimes there's emotional and psychological included in those estimates, but it's not always the case. So understanding how we incorporate those different dimensions is something that our team is currently working on. And then finally, in the context of COVID-19, which I'll talk about in just a minute, is sort of the spillover benefits between robust adult immunization systems and future pandemic preparedness. So if you have robust adult immunization systems, you have the channels that may be needed to address pandemics in the future that require adult vaccination in a way that is more smooth and streamlined. And then there are also potential interactions between things like COVID-19 and adult immunization more broadly. Other members at my research centers, led by Lois Priver-Dum, who is our head for adult immunization and aging, have developed a framework to think about adult vaccination in the context of COVID-19. So I just wanted to highlight this here. Here's an example with flu vaccine and sort of laying out the trajectories and outcomes of those who have previous influenza infection and then experience a COVID-19 event later on, and their post-COVID-19 functional ability. And this is based upon preliminary evidence from studies relating previous infectious disease vaccination with future post-COVID recovery. And so one could expect this to be similar in other settings as well, and with other infectious diseases. And this is analogous to sort of what we see with chronic conditions, that there can be multiple trajectories of chronic condition within the same individual, and vaccination for a disease that interacts with that later chronic condition can lead to a divergence in those pathways. And developing the cost associated with each of those pathways is crucial for placing a return on investment number on adult vaccines. So just to highlight some evidence and sort of the importance of all of this, one thing that we found in sort of our work is that there's limited evidence right now on the return of investment out there and sort of what the economic value of these things are. One study we have found, led by JP Sevilla and others at Harvard, have found in Denmark that among older adults introducing PCV13 vaccine has led to about 149% return, which is about 1.5 to 1. Sort of on the scale of what we look at in the general population in terms of the benefits from averted cost of illness due to treating disease later on. But when you take a look at subpopulations, so as we saw before, those with diabetes are of particular concern. If you narrow in that study to those with diabetes, you see that there is about a 12 to 1 return for those patients because there's such a strong interaction between pneumococcal events and diabetes, and so it averts even more. And so why is this important? Why do we really care about putting an economic value on all of this anyway? Isn't health, just enough to talk about this? Why do we need to put a dollar value on things? And you can see here, we've done sort of an analysis at the Vaccine Access Center on respondents and their influencers in terms of adult vaccine decision-making. And you can see some higher income countries and how they rate different factors. And some of the factors that we've asked them about are cost effectiveness, health security, disease burden, safety and efficacy of the vaccines, the presence of sort of champions and advocates, the degree of advocacy, and sort of other decisions. And you can see for most countries, cost effectiveness falls pretty high on that spectrum. So it's a very important decision sort of across the board with countries such as the UK placing it as one of their top priorities and top things that come into account when thinking about immunization. And it's, above 2, which 0 being the lowest importance, 3 being the highest importance on our scale, fairly important for all countries. And in addition, health security, you see, is extremely important for a lot of these decisions. And so documenting the interactions between things like these infectious diseases that we know about and can prevent and future potential pandemics is extremely important. So doing this economic analysis has benefits in terms of getting the discussion going on the policy agenda and making an informed case that advocates can then use and others can use to sort of document the impacts and make a case for expanded investment in adult vaccination. So for more information on any of this work, you can visit our websites. I'm sure Jane and Sheila have circulated these around. And just to highlight our many wonderful collaborators and stakeholders and people we've worked with throughout the course of the Decade of Vaccine Economics project, and who we hope to work with going forward on work focusing more on adult immunization. And our work was funded by the Bill and Melinda Gates Foundation.
Thank you very much, Dr. Patenaude. You know, in both of these presentations, we've really had, you know, a richness in the information and the knowledge that both presenters have delivered. You know, Brian, I was struck by, you know, once again, the intersection of vaccine preventable diseases and chronic diseases and the importance of that. I guess one of my questions that I'll just put in the parking lot is, how do we do this analysis when, you know, not all countries have national registries? So, you know, I think it's a real question for me about, you know, registers and surveillance, etc. You know, I was also struck about, you know, the work that you are doing in understanding functional capacity. So perhaps, you know, both you and Jean-Pierre could have a discussion about that. And finally, in your last or second to last slide, you know, the importance of champions and advocates. So I'm almost gratified that, you know, that was certainly there, and that organisations such as the IFA, as well as many others on the line today, ILC Canada, UN representatives in New York and in Geneva. So we have a role to play in helping to influence and shape policy and encouraging governments to look at the investment. So perhaps we can move on to some questions. And in this webinar, what I'll be doing is I will be communicating the question. So we'll start off with three people. Eileen, in the context where there is high acceptance to receive a vaccine, such as the current one for COVID, and there are different product suppliers, how can the public judge which is the best? So that really is about, for the first time, I think, many of us know these words such as AstraZeneca and Pfizer and Moderna, whereas it's interesting, you know, if it comes to flu season, we don't know the names of vaccines or the industry supplier. So that's one question. You know, from Marilyn, health professionals informing the public, the use of mass and social media will be very important in promoting or countering misinformation. So perhaps if you can comment on, you know, the information in the mass media and how that impacts vaccination uptake rate, because we need to also think beyond COVID and pre-COVID. And the third question in this series is Dr. Cynthia Stewart, and she said, incredible presentation, Jean-Pierre. How can we get the good news out about the data on long-term positive impact for older persons to be immunised and the importance for childhood vaccines? So 3 questions, one about, you know, choice of vaccines, the second about mass and social media, and the third about how do we get the good news out. So I hand it to the floor. Jean-Pierre, would you like to kick off?
Yeah, I can do it. I think that for the COVID vaccine, there is no discussion actually, because the availability of the vaccine is not so important. So we have to use the vaccine that are available. And I know that in Europe, there is restricted number of vaccine available. So I will not choose any vaccine. I will take the vaccine that is proposed to me currently. But perhaps we have to consider, it is just a glance to Brian, that the prices of the COVID vaccine would be very different from the RNA vaccine to the other vaccines. And I think that it could be very important for government to choose what kind of vaccine we will have to use mainly. But I think that for the other vaccines concerning flu vaccine or other vaccine, I think that, for instance, I don't think that it's mind too much to know exactly what kind of vaccine in each category you have to use. the most important is to be immunized. And I think that it is really what is the key message.
Mm.
The second point concerning social media and mass media, I am completely struck by all the information that we can get. And I'm not looking too much at mass media and social media, but I have friends around me who are looking at them and very trustful on them. And there are very misunderstanding, misinformation, which are very intolerable. But I think that the most important problem behind it is the health literacy and the vaccine literacy. Because when you are looking at, I will speak about Europe, few data were done about health literacy in Europe, in 8 European countries. And you can see that almost 50% of the population is not able to understand the health information and vaccine information. And I was very surprised because there is one study which struck me a lot. They ask people who go to the cancer 5 years after the cancer, it was in France, 5 years after the cancer, they ask people to read hospital notice, hospital leaflet, and 37% of them were not able to read without any help the hospital leaflet. 5 years after a cancer which was treated. So can you imagine that a lot of people are not understanding the messages that you are giving them? And if they are strong or misinformation, they are spreading it without any appraisal of the quality of the message. The last point, how we can do to know the long-term effect of vaccine, that is a very important question. I present you data from Canada, and it is the only one data that I know, unique data that I know, concerning infant vaccine and old age dementia. And this study was performed and published in 2001, and no other study were published on this topic. So I think that it's very difficult, but perhaps, as said by Jane, national registers, good national register, could perhaps once help us in this way to answer this very important question.
Look, thank you, Jean-Pierre. I'm going to move on to a couple of other questions, Brian, which are directed to you. But at some stage, I would like a response from both of you about the safety of COVID vaccines, because it comes up constantly. So I'd like you to just state your views. But let me go to the questions which are directed to you, Brian. A gentleman, a person from Ethiopia, has talked a lot about in the chat box, that the economic factors, for older people to be vaccinated are certainly, part of the case. So perhaps if you could talk a little bit about your work in low and middle income countries. Dr. Birgia Glittman, and I believe that Hava is in Austria. She says, are there comparative studies comparing a vaccinated versus a non-vaccinated society for economics, expenses for health, happiness and social success? And then she reconfirmed, what we see are estimates. I mean, a comparison of the real facts and balances of the societies that are compared. Would you like to just talk with us a little bit about, the low and middle income country and the difficulty and the challenges that you experience in economics of vaccine, and then to Hava's question.
Yeah, sure. So in low middle income settings, obviously there's a lack of often information and registries on sort of the conditions that come in. A lot of health information systems aren't able to sort of link the diagnoses and the different conditions that are coming in at the district level to those sort of the estimates that one would need to sort of take a look at this. It's just the landscape and burden of disease. The data is getting better in a lot of settings, particularly for adult immunization relevant conditions and chronic conditions. Those data aren't as readily available. So there have been a lot of investments in sort of tracking and monitoring infectious disease in low and middle income countries, and particularly those that are pediatric vaccine preventable. But there's less well documented data on sort of these chronic conditions and older conditions. So that's certainly a barrier. One thing that we've done even in working in pediatric vaccination is go into the countries, spend a couple of years collecting data, going at random facilities and documenting all of the cases that are presented in those facilities with a disease that could be documented as being vaccine preventable. I mean, we've done that for children. We've done that with measles. We've done that with the rotavirus. We've done that with other things and settings. And so, you know, maybe the first step is sort of doing a study like that in a particular setting and getting an idea of on the ground what it actually means. Because not only do we have the discrepancy in recording the disease and recording the information related to that diagnosis in low and middle income settings compared to high income settings, but we also have a huge variety of the cost of care associated with that from an economic perspective of what that means. And that varies not only between countries, but between levels of facilities. Like you may be going to a district hospital in a certain setting versus a large central urban hospital in another, or a clinic, depending on where you're seeking care and what the condition is you're facing. And there may only be a limited number of facilities that can treat a certain condition. So it's important to sort of take all that into account and do a detailed job of sort of documenting the trajectory of the interrelated illness before even getting into the vaccine part of it all. And the vaccine part of it all can come a lot from scientific data that's collected, you know, globally with a medical interaction between vaccine preventable illness and this. And yes, it's important to take that into context of low and middle income countries, but it's a bit easier from what we do in other realms of this work to extrapolate that. But actually getting an idea of the costs and expenses that are done for these chronic conditions that interact with adult immunization preventable disease is extremely important.
Okay. So a comment and question from Dr. Vinod Kumar from India. Vinod is well known to IFA and I'm sure an IFA member. There's two questions. What's the minimum percentage of population that has to be immunised to get herd immunity for the entire population? And let's choose influenza for that. And is it economically feasible to immunise huge populations with a non-COVID vaccination like flu in a low-income country? I think it's a question. So do you have any comment, Brian? And then I'll go to Jean-Pierre.
I mean, I think there's a general popular rule of thumb that above, 60% can give you herd immunity, but that's not really true. It depends upon, what epidemiologists call the basic reproductive number, sort of how many people an infected individual then transmits the infection to, so sort of the rate of infectivity of the disease. So, I mean, it may be much higher than that. But I mean, as a rule of thumb, you can think about sort of for some things about 60% before you start getting herd effects. But it may be higher than that depending on what the disease is. So I guess that's one thing. Oh, go ahead.
Yeah, Jean-Pierre, public health seems to have come to the forefront, in the conversation about COVID. We hear public health professionals talking a lot now. Do you think that is going to help improve the vaccination rates of healthcare professionals? Because we know generally, we're very concerned often that of the low rates of vaccination in healthcare professionals. Do you think that this could help?
I think that the problem of the vaccination of healthcare professionals is a true problem. When I was the head of the geriatric department in Geneva, I did my best with my colleague in the medical team, nurse team, and also healthcare professional to be vaccinated and to promote vaccination. And we never get more than 1/3 of the healthcare professional vaccinated. And the healthcare professional don't believe, I don't know why, in vaccine. And I think that there is a true problem about their education on vaccine and their knowledge on vaccine. I think that it's a key problem. But to come back to your question, I think that COVID vaccine, who was really discussed in France in the global population. At the beginning, everyone refused the vaccine, or quite a lot of people in France, particularly more than 45% said, no vaccine. And now all the population is going to be vaccinated, and we will not have enough vaccine. I'm sure the healthcare professionals also will be in the same way. So I think that, and it is very interesting to have a look at the different rules established by the different governments. In France, they said we will vaccinate firstly the very old people in nursing homes. And then the healthcare professional above the age of 50. If we are going to Mexico, you can see that the first goal and target of the Mexican government is to focus on the healthcare professional, and then secondly, to the old people. And I think that it's something that we have to think of, but I'm sure that to answer quickly to your question, I'm sure that the COVID vaccine uptake will be very high.
Well, look, you know, if there's one for me today, I'm going to get it, all right? But there's not. I will have to wait. I want to talk to both of you about quite a touchy subject, and this is mandatory vaccination. Now, some countries, you know, have, you know, loosely talked about it. So in your experience, both of you, how useful or not is legislation to ensure vaccination rates are almost 100%? And I'll give you the example. You know, I think, you know, in Australia, you know, there could be some policy, I wouldn't say it was legislation, around measles. But I would be interested with your views about adult vaccination. And, you know, what's your experience and how useful is it? Brian, would you like to share your views?
Yeah, sure. So, I mean, this is a difficult question. It depends upon a number of things. One is sort of what the relationship is in the society where you're talking about this mandatory vaccination between sort of public sector guidance, but in this case, public sector mandate and the ability of the public sector to say what's good for the population, and then public trust of that information. And so this varies widely across settings. There are documented studies showing sort of, you know, different preferences among individual societies for belief of government information, for trustingness in general, for the, you know, wantingness to participate in the public good over sort of individual choice and freedoms. And I think that's a very important discussion. I'm based in the US. There are very particular preferences that exist among the population in the US that may be different from other places in the world. And often, you know, mandates for anything are faced with skepticism and may not actually end up in achieving the results one wants because of then the distrust of information that circulates around that and different ways to go about opting out if that's possible. So I would say that, you know, in some settings it may work well. In other cases, maybe there are more behavioral approaches to influencing people to want to get to that rate that may be more appropriate.
Jean-Pierre, your view?
I think that in the European media, it was very surprising to see that more and more we are going to this idea of mandatory vaccination for COVID, for example. And it was very surprising, and it was the first time that I heard this, that a lot of journalists at the radio and in the journals are saying that, in fact, for the children, we have now in France 11 mandatory vaccines. It was discussed at the beginning, but if the children did not get this kind of vaccine, they cannot go to school. And indeed, the level of uptake is now 98 or 99%. And it was not discussed. It is exactly the same thing when you are going to different countries, African countries or different countries, you need to have the yellow fever vaccine, and it is mandatory. So more and more, as the COVID pandemic is so stressful for all the people, in the media, they are speaking of the mandatory vaccine. And if in Europe, we don't have this kind of mandatory vaccine until now, it is because the people who are against the vaccine has to government have to take care of this kind of opinion, that perhaps by different kind of ways, the vaccine would become important to go to the cinema, to go into a plane, to go to the sport events, to go to the leisure event, and perhaps the population will change their mind, and perhaps we will never have mandatory COVID vaccine, but more and more we push people to be vaccinated.
Jean-Pierre, I want to go back to your comments about health literacy. The IFA has just completed a 10-country study where we analysed the public health messages from government on adult vaccination and influenza vaccination. And what we found was the messages were exactly the same. It was the same message. And by that, I mean, it was standard text, and across 10 countries, it didn't vary a great deal, which then got us thinking about it. There is an assumption in those messages that everybody has the same level of health literacy. There's an assumption because there was nothing different at all. And even more so that if we're talking about influenza vaccination in some countries, the at-risk groups were pregnant women, older people, and it was all in one bunch. So I'm really intrigued, with your thoughts going forward, about how can we really break the mold of this universality of messages, because another piece of our work that Anna Sangster is leading at the moment is about ending inequity. And we're really trying to understand, inequity. So could you sort of provide a bit of comment about
I can comment, but I have not the solution. Because it's very complicated. But I was completely afraid by what I discovered when I was looking at health literacy and vaccine literacy. And I think that perhaps we have more to focus on school children to start very early in life and to repeat the message several times. And perhaps the COVID pandemic could help in this way too. But I was really completely afraid, as I said, by this disadvantage. And when I was speaking with my colleagues, they said, oh no, I am not surprised of your results, but how to manage it, how to change these things. And I can tell you that at the Academy of Medicine in France now, we are working on this topic. And perhaps in a few months, we will have a solution from Europe and from Latin America, telling you what to do to increase this kind of health education.
Brian, I just want to go back to some of your work and talk safety and hesitancy. And, I'm now, as Jean-Pierre is saying, this is very complicated. This is not just a black and white, red and pink. This is very complex, and it's situational specific, and it's generational specific. It's very complicated. But in your work, are you doing any work around vaccine safety and hesitancy, and how that impacts investment in the business case?
Yeah, so my own and personal involvement on vaccine hesitancy and safety is less, but at the International Vaccine Access Center, which I'm a part of, we actually have leads for vaccine safety and vaccine hesitancy, and their work sort of leads into our eventual work. So for safety, we do take a look at cases of adverse events related to vaccine. We do incorporate that into our economic assessments of vaccines as is necessary, but then there's also research done on sort of how to present safety, how to ensure safety for different things and different timelines of vaccine with vaccine introduction, how to effectively monitor safety, and how to disclose that safety in a way that is meaningful to public interpretation and public absorption of that data to build trust in vaccination systems and to allow for early alerts if something goes wrong. And so this is extremely important with the COVID vaccines, and the rapid timeline where they're developed is like making sure that we have these sort of systems and we have this chain to go through. So I think that's been really important. I will work more on the back end of that stuff related to quantifying that in economic terms.
So just another question, it comes back to your work on function. And I think this is so critically important. You know, one of IFA's other work streams is on vision. And, you know, there is a vision acuity, but in terms of functional vision, that's much more difficult to understand. So, you know, in the context of your work about, you know, investment, the economics, where does function fit in, and to what degree have you been able to unpack it?
Yeah, so we're still in the stages of working on unpacking what that means and how you quantify it, but there's been a lot of work to sort of get prices placed on functional improvements. And part of that has to do with translating functional improvements to things that economists are familiar to working with, like quality adjusted life years, and ways that you can sort of convert functional reductions from 100% age specific or accepted sort of functionings to those quality of life reductions that economists are so familiar with working with. And so there's a lot of survey-based approaches going around right now in higher income countries, working with adults at various life stages with various conditions and trying to generate values associated with these reductions from full functioning. And then as modelers and economists come in later on, using those values and extrapolating what they mean based upon the clinical characteristics of those conditions in other settings until we're able to get better primary data from those settings. So I think that's sort of where we are. We're still at the early stages of understanding that. There's a lot of work in sort of the economics and health economic space that's being done to take a look at that, but we're still at the sort of early stage on medical side and clinical side of connecting those functional impairments, both psychological and physical, to the actual quality of life reduction and what that means.
You know, as advocates, there are many organisations on the line today that are advocating for the rights of older people. And rightly so, in the world of the recently released COVID vaccines. You know, is there a case to be made for older people having the right to access vaccines? You know, it's a very open question, but, you know, it would be useful to hear your views about that. Either one of you.
Go ahead, Brian.
Oh, yeah, sure. I mean, absolutely. I think that having a right to this vaccination, particularly, I mean, with COVID-19, with a condition that has such severe outcomes for the older population compared with younger populations, with such high infection rates. I mean, you can clearly see the disproportionate burden as you look at the statistics and numbers, and it really is sort of an impediment to the ability to live daily life, even just living with the fear of, you know, potential of not knowing, and the sort of the cognitive and psychological factors that come in with that are something that's extremely important, and that, you know, one should incorporate into evaluation of the benefits of something like this. So I think that rights-based approach, you know, fits in well with all of that and is translatable into dollars. We have very good ways of measuring sort of psychological stress and how psychological stress translates into economic value. So that's certainly something that can be factored into these types of analyses as well to give it maybe a more tangible value.
We'll be coming to contact you, Brian, all right? So that's exactly what we need. Jean-Pierre, your thoughts on that? Is it, you know, do we have a right as an older person to have access to this vaccine?
The main problem of vaccinating the very old person is in fact that they are often very frail and disabled. All the people are speaking too much about multimorbidities, but not about functioning, daily functioning, frailty and disability. And you spoke just previously about the safety of COVID vaccine. And I was very surprised because in France, as in Switzerland and Europe, we did not heard a lot about the problems with side effects of COVID vaccine. And just yesterday, In France, in Switzerland, and in Europe, we heard that a few old people living in nursing home died. There are in France 5 deaths from after a few days after the COVID vaccine, and that 500,000 of people were vaccinated. And the people who get the vaccine at the beginning, got the vaccine at the beginning, were the most old, the oldest, the most disabled, and the most important multimorbid people. And indeed, the rate of death in this kind of population is very high, and it is not linked to the vaccine. So which is very surprising. And I think that all people, and particularly all people who are well functioning, are willing to get the vaccine because they are sure that, in fact, they will get something to protect them to have a quite normal life in the near future.
Look, thank you for that. As we move to wrap up this session, I'm going to ask both of you to provide some key messages, to our audience. In closing, I want to thank Sheila Amory for your great efforts in leading this body of work, and also Berenice and the IFA team. Our next webinar, as part of the Building Global Momentum for Adult Vaccination in COVID, is on the 10th of March, and it's not to be missed. It's on equity in vaccination coverage for all ages. So please be with us. Sheila will send notifications out, but it must be heard from the experts, and we have a responsibility to actually come together and have a common approach to ending inequity in immunisation. So I'll start off in reverse. So Brian, your final comments to our delegates today.
Yeah, sure. I just want to highlight the three sort of key messages. The one is that, data on the interactions between infectious disease and chronic conditions in older adults are starting to be documented, but we have a long way to go. And that is essential in sort of building the entire investment case for adult vaccination. So more work needs to be done. The second is that this work is going to involve the collaboration of not just medical researchers, but medical researchers, epidemiologic modelers, economists, stakeholders, policymakers, to determine, what the right way is to talk about this, what the right things for the right people to include in an analysis of the return on investment, and how to compare this in an apples to apples way to other health investments we might want to make. And then finally, in the context of COVID-19 and future pandemics, the importance of robust adult immunization systems as a health security benefits, in addition to just the health benefits that those immunizations provide directly, and how there is likely an interaction between the delivery of other vaccine preventable, the delivery of vaccines against other diseases and future pandemics going forward.
Thank you very much, Brian, for your work, for your presentation, and for your leadership in this area. There's not too many economists in your field that actually can talk function, qualies, delis, and put it into a way that makes sense to someone like me who's not an economist. So we thank you for your time today, and for always, stepping up. When we contact you, there was no problem at all. You were there. And so thank you very much. Jean-Pierre Michel, your final comments.
Yes, I have 3 of them. The first one is, as I tried to show you in my presentation, many beneficial effects of vaccine, and just Brian said, chronic disease, functional abilities, have historically been under-recognized until now. And we need to include them in the immunization process and immunization thinking. Secondly, I think that scientific benefits of vaccines are unfortunately counterbalanced by misinformation. And I hope really that artificial intelligence could help controlling messengers and messages. And the third is to say that I am quite sure that communicating the full benefits of vaccine, and indeed economic aspect also, could help to regain public confidence in vaccines and vaccinations.
Look, Jean-Pierre, once again, you've surprised me. I've known you for quite some time, but you always deliver something to me that takes me back, and then I think again. And so for that, I'm grateful, and thank you for your key messages. You know, what we've had today is two intersecting presentations. But more importantly, we've had professionals with vast experience that have come to us today and been able to explain some very complex situations around adults, immunisation, vaccination, investments and economics. You know, the title of the session today was The Case for Investment in Health Prevention and Promotion. And that also means that governments must work to reorientate their systems to promote and prevent rather than being at the forefront of curative. And immunisation, you know, is part of a comprehensive, sustainable,